Now I won't. Welcome, everyone. I'm Corby Cummer, Executive Director of Food and Society at the Aspen Institute, and thrilled to see this crowd here because nothing is more fun than talking and thinking about food. And no one is more knowledgeable about food and health and making better food than our panelists today. So I'm going to say a quick word about the work we've done at Food and Society, and then invite Pam, who's been one of our guiding founders in all the work we've done on food as medicine. So food as medicine is a very attractive term because it makes us think that what we eat can probably help our health in every way. It can help prevent illness, it can help stave it off, and it can help treat illness. That's all true. In the way that it's
food in the back.
You know, I think there might be human food that could be very helpful right now.
We've got some food insecurity issues going on in the back of the room.
That's right, personal food
Nutrition
insecurity. All of these terms, you know, food is medicine, the idea of insecurity. That's loud, audible insecurity, but it generally means not knowing if your family will have enough means and food to serve meals to all of them within the course of a month. That's often, it's now an official screening question. And in fact, when people screen for food insecurity, they're generally referred to the healthcare system in a way of finding food. That is the way we at Food and Society at the Aspen Institute and a lot of healthcare providers have used the term food as medicine. So we're going to be talking today about the idea of making less expensive, more accessible meals that will help prevent chronic illness and help treat often diet-related chronic illness, and getting it as a covered benefit. This is a red cape in front of Pam Schwartz because she thinks that the Holy Grail might not be only making nutrition a covered benefit. But when you hear and read about food as medicine these days, it's mostly the idea, how can we get healthcare payers and national insurers like combined Medicare and Medicaid services, various innovation funds, to actually make it a covered benefit and get it out of the pilot phase, because it's been largely in the pilot phase. Pam is going to, correct and disagree with me and talk about what the needs for food as medicine are. But she was instrumental in helping us gather the country's top researchers to make sure that there is one guide to what all of the peer-reviewed research into various food as medicine interventions, namely medically tailored meals, medically tailored groceries, and produce prescriptions like New York City's green carts, which have been incredibly innovative in getting more food, fresh food to people. What do they actually say about improvements in health? Where's the evidence? The evidence is right in Food and Society's report, and I'll say a little more about what work we're going on to later on. Pam, can you talk about, Pam is at Kaiser Permanente, and whenever anyone wants somebody to talk about food as medicine and its relation to the healthcare system and how healthcare payers should think about it, they all go to Pam, and Pam amazingly says yes and shows up. How we don't understand how she's on as many planes as she is, and she comes to Zooms and she points you to different people who are doing the work, doing the research. So how is it you got interested in food as medicine, helped define it as a term, and what's your working definition now?
Yeah, well, thanks, Corby, and thanks for having me. And it's so great to see such a, packed audience here. It's obviously a hot topic. Well, I want to maybe just start with saying that we all know that nutrition is important to getting healthy and staying healthy. So that's not something that is argued. We don't need the evidence for that. What we have been struggling with, I think, as a field is what are the right interventions and how do you integrate it into healthcare and how do you pay for it, how do you scale it, how to sustain it. So how did I get into it, Corby? Well, Kaiser has a long history of obesity prevention, diabetes prevention, and that's been going on for years. We had our very first farmers markets put in by one of our physician champions, Dr. Preston Mehring, back in 2000. So it's been part of our DNA, if you will, for a really long time. But about 6 years ago, our former CEO, Bernard Tyson, asked the people of Kaiser Permanente to come up with their best ideas for creating healthier lives, and it was crowdsourced. A bunch of ideas, there were about maybe 3,000 ideas, and what rose to the top at that time was food insecurity. So that's how I leaned in the very beginning, and honestly, your invitation to sit on the Aspen Institute's report that you just mentioned was my very first invitation, so it really was, and this was in, I think, 2019, maybe?
It opened the floodgates, let me tell you.
Yes, it opened the floodgates, yes. So, and it was an honor, really, but maybe just, so it was crowdsourced, and then we started rolling up our sleeves and planning, okay, what does this food as medicine portfolio look like? And we weren't even calling it food as medicine back then. We were calling it first food insecurity, then we switched to nutrition insecurity, which is why I made the correction of the crying,
I'm
crying
glad
baby.
I was setting you up.
Because it's really also about like not just do you have enough food, but do you have enough healthy food to get and stay healthy. And so we started with a portfolio of interventions. Our very first intervention, actually, because now you asked me to correct you, I'm going to correct you, not correct, but I have a broader view of food as medicine because our very first food as medicine strategy was SNAP enrollment. So we knew that there were people eligible for SNAP that were not enrolled, and we knew that having dollars in your pocket to purchase food was very important. So to date, we've reached out to over, I think it's now over 5 million, maybe even close to 6 million of our members. We have 12.6 million members to help them get enrolled and stay enrolled in SNAP and WIC. And so we've scaled that across all of our markets.
A quick interruption. You all know that SNAP are food stamps.
Thank you.
An enormous 80 billion part of the food bill. And WIC is women, infants, and children, which began decades before food stamps and is considered the sort of definitive government nutrition intervention that meets the standards of food as medicine because it has a lot of nutritional definitions
Thank you,
and
Corby.
requirements.
Thank you. Yeah, so these were government programs that people were eligible for and not receiving. And we wanted to look at the role of healthcare in helping people to get enrolled and stay enrolled. And so then, fast forward, we started then trying to build the evidence, seeing that food as medicine is coming into play here, but there's still a gap in the evidence. At that time, medically tailored meals was the most evidence-based, but there was very limited evidence in things like medically tailored groceries and produce prescriptions. And so we started leaning in there to help build the evidence, and we're still working on building the evidence and the business case. So things like, how do you implement it? What disease categories? Which target populations? What is the dose and duration of the interventions that are the most impactful and also have quality in mind, equity in mind, and outcomes and cost in mind as well. And so fast forward a little more, and now we're in 2022. The White House holds a conference of hunger, nutrition, and health. It brings together leaders from across the nation. We, Kaiser Permanente, they asked for commitments, and we committed $50 million towards really turning it on, really accelerating the work that we had already started to just build more into a more robust portfolio of food as medicine interventions and partner with others. There were many innovations that came out of that conference, many new partnerships, innovative partners, community partners and business partners, healthcare partners, government partners, and so we leaned in partnership with others. And then, maybe what's most exciting to me and really hot off the press, just in April, we launched what we think is the very first Food as Medicine Center of Excellence in Healthcare. And so building off of the work that we've been doing over the past 5 or 6 years and doubling down, the NIH put forward a framework last summer for a Food as Medicine Center of Excellence. We took a look at it and said, well, we are in this space now. What if we turned it up a notch and really embraced it?
I'm entirely crediting Pam's contributions to the Food as Medicine Research Action Plan, which is what we released. But then I'll say the NIH, in its Centers of Excellence call for food as medicine, the first words were a report from the Aspen Institute. And our principles, especially about equity in research, guided the whole thing. So we were thrilled that it's actually happening. But speaking of the actually happening, You, Pam, and Kaiser Permanente, first remind us, if you would, about the difference between an integrated healthcare system and what sets Kaiser Permanente apart from many healthcare payers. We have Mount Sinai in the room, and they've done a lot of food as medicine work themselves, but what that was like and whether it took buy-in to get, and also, what's the difficulty in persuading large healthcare payers to think about this, because one of the reasons we have large studies is because Pam has helped fund them and called for them at Kaiser Permanente.
Yep. So we are the largest nonprofit integrated healthcare system in the country. And so what does that mean? We're both a payer, so a health plan, health insurance, and providers working together to care for people using value-based care, a team-based approach. The last session that I was in, people were questioning the value-based care. I think some of you are in the audience, the word value in it. But anyway, it's really about a focus on prevention, a team-based approach, and we spent the past 6 months really thinking about what would a food as medicine center of excellence using the NIH framework look like inside Kaiser Permanente. And so we brought together about 400 people, mostly internal, from across our organization. So frontline care delivery, hospital leaders, research leaders, line of business leaders like Medicaid, Medicare, commercial leaders, members. We brought together almost 40 members to really roll up their sleeves with us in the design. We had a physician, and we still have a physician advisory committee from across all of our states. These are frontline physicians that are leaning in to make sure that what is on paper can ground in practice, and because they are seeing diet-related disease on the front line and hunger, and so we wanted to make sure that what we were designing had the end users in mind. And the end users, as I think about them, are the clinicians as the end user, frontline care teams, and also the member/patient as the end user, and also our communities. And the NIH framework has all of those in it. So it has what do you do in care delivery, what do you do with your community/government/other business partners, what do you do in research and innovation, and what do you do to educate your workforce? So like we have a world-class med school. I think our leader I saw him walk in. Oh, there he is. So we have a med school that just graduated its first class. We have world-class research in all of our markets. And so to your point, we could stand up studies. We're sitting on a mound of data. We have solid researchers, and so we could ask questions and answer them. And that's what we've been trying to do, like pull all of those levers and also inform the field so that we're part of the national dialogue as well, the policy dialogue, the evidence-based dialogue, the bringing along our healthcare peers dialogues, and making sure that we're not just looking inside our own walls, but sharing it with the greater good.
Great, you've teed up Jerome. So, and I'll also say, Pam is actually doing it, and I hope by the end of this session, all of you who are affiliated with healthcare systems are going to go out charged up and storm Pam and say, how did you do it, and what does it entail? Jerome, your own interest in nutrition, and we're talking about seeing people on the front lines and caring. You've been a doctor, you've been a policymaker, the country's Surgeon General, but you have a personal commitment, I think, to nutrition and better food.
I absolutely do. I'm someone who grew up relying on SNAP and WIC and free lunch at school in order to make it to being here before you today. So I very much appreciate the insecurity that exists out there, and it's something that I bring with me that frames the way I think about all problems. One of the toughest things about being Surgeon General is that everyone wants to make their number one priority your number one priority. And people ask me all the time, how do you prioritize? And one of the ways that I try to handle that is to get to root causes, to say, okay, what are the root causes? So you want me to focus on diabetes, you want me to focus on hypertension, you want me to focus on asthma, you want me to focus on cancer. Well, at the root of all of these is what we eat. And if we can actually help everyone eat better, then we're going to solve, or at least help mitigate all of those different diseases. But I want to try to give you all a different perspective. So what's interesting about me is I'm at Purdue University right now. I'm the director of health equity. And I had offers to be health equity, blah, 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 fill in the blank at a number of different places, including Indiana University Medical School, which is where I trained. And I had to really challenge myself because I have an MPH, and I go around and give lectures and tell everyone all the time that only about 20% of your health is determined in a hospital or a clinic. The other 80% is determined in your community, and it's determined by things that happen outside of the healthcare system. But we keep doubling down on what I call the medical model, trying to change things within the healthcare system and the healthcare ecosystem. So I went to Purdue, that doesn't have a medical school, but we have the #2 college of ag in the country. So we're literally designing your food. We've got the vet school. So we're talking about how do you feed a cow to change its nutritional content. And we've got the #1 biomedical engineering school in the world. So we're talking about how do we design devices to interact and give us data on folks. We've got biochemistry, so we can talk about the gut microbiome. I see you out there. We had a great conversation about the gut microbiome the other day. And we actually talk a lot about food as medicine. It's one of my pillars, except we don't call it food as medicine because that's doubling down on the medical model. The medical model is diagnose and treat disease. And it's why we spend 3.5 times as much as the OECD average on healthcare in this country, but we have lower life expectancy and terrible results. We've got to break outside that medical model. We talk about food as health. And so I think that's important, that we think not just about, the medical model is important, and everyone has to lean in where they have a lever, but if we're only nibbling away at 20% of the problem, we're not going to get to where we need to be. We need to think about what's happening, again, with all these other partners out there who we can bring to the table. So that's one important point that I want to bring up. Another important point I want to bring up, and I was teeing you up on the food insecurity and nutrition insecurity. I believe they both exist. There were times in my life I was food insecure. I don't care what you give me, I just need to eat. There are also a lot of people out there who are nutrition insecure. I have a family history of cancer, a family history of diabetes. I have high blood pressure. Are we eating the right foods? That's nutrition insecurity. But for instance, for diabetics, diabetics don't show up in DKA on a population level because of nutrition insecurity. You get a spike in diabetes admissions at the end of the month when people's SNAP benefits run out. They are food insecure. And so we need to lean into that. And I want to give you kudos here because one of the top interventions out there for actually improving people's health across the spectrum is making sure everyone who is eligible for SNAP and WIC gets signed up for it. And so anything you all can do as a nonprofit, as a healthcare entity, as a community partner to actually help people access the services that are already available out there to them, it's going to make a huge difference. That is the #1 predictor of whether or not you're going to take someone who is in poor health and get them to higher health, because the insecurity is a big risk factor. Final point I'd make is about policy. W. Edwards Deming said every system is perfectly designed to deliver exactly the results that it does. And we need policy change. We need systemic change. And I'm going to give you 2 quick points, and then I'm going to turn it over because I do want this to be a conversation. From a policy perspective, we do need to think about payment. And I'm a little bit concerned about this focus on reimbursement because it's still doubling down on this fee-for-service model, this diagnose disease, treat it, and then pay someone for treating that individual. It's why I got my MPH. It's why I got into public health, because I love practicing medicine. I still practice medicine. But I got frustrated that for every person I treated, there were 10, 100, 1,000 more out there who I couldn't treat. We need systemic level changes to occur. And so we need to change the way we pay folks. And I actually am whatever you want to call it, I am a big supporter of risk-based, value-based care, so that instead of paying someone to give food to an individual, you're actually rewarding healthcare entities for thinking about food for everybody who they're caring for in their payer panel. I think we do need to figure out how we can come up with new and innovative payment models and shift from fee-for-service to value-based care. I think that's incredibly important. And then I'm going to say something controversial that I'd get fired for if I was still Surgeon General. But I'm going to ask you all a question. Where does the first Republican primary take place? Iowa. And they are what's their #1?
There must be a trick question.
What's their #1 crop?
Yeah.
Corn. And if you've read The Omnivore's Dilemma, 60 to 70% of the food that you consume in the grocery store has corn or corn byproducts in it. So we are not going to be able to change the system as long as we are addicted to corn and to foods that actually are bad for us. Even the fish you eat. And again, if you haven't read The Omnivore's Dilemma, it's an older book, but it's amazing. They are grass-fed beef versus corn-fed beef. Even fish. I try to eat more fish. I'm trying to evolve to be pescatarian myself because I love seafood and it's got health benefits. But farm-raised salmon is worse for you than natural salmon. And you know what that farm-raised salmon and that farm-raised beef and that farm-raised corn has, farm-raised chicken has? It's corn. They're force-feeding them corn. So we have to really understand we're not going to change on a large scale unless we think about policies that are contributing to the system that we have that's delivering exactly the results that we're getting.
Great, and we have to change the payment structure. So a couple things I'll add.
Wow, I haven't gotten applause for a long time.
So individual diets, really crucial, and what we're generally talking about is that 80% and getting everybody a chance to eat more food rather than individually tailored diets. So we want everybody to have a chance to have better food. And the next work that we're doing at Food and Society at the Aspen Institute is a getting started guide for healthcare centers that haven't done food ever. What does it mean? Where do you find the money to implement it? And then very importantly, what data can you, a tiny healthcare center that has like no space and no person power, but still, what can you collect and contribute to larger studies that will help build the case that this really is preventative and really important? So we next come to Tom because so much of what Jerome was just talking about, first of all, he said something that was sort of setting Tom up saying, we at Purdue engineer the food so it's better for you. Well, that's exactly what Tom does at Pairwise, which is a company that uses genetic engineering techniques and CRISPR to make fruits and vegetables that taste better, are easier to raise, and easier to eat. And tell us more about that.
Sure. Yeah, there's a lot of setup there. I think maybe one of the things, just to step back, is I think one of the things, I guess it's equity would be the right term. We're all actually pretty good equity in the fact that most of us do not eat enough fruits and vegetables. I think it's about 10% of people. I could ask people to raise their hands, but really only about 10% of people.
No shaming in this room.
Eat the recommended amounts of fruits and vegetables. Yet we all know from when we were young and our mothers were telling us to eat our fruits and vegetables that we should, and there's lots and lots of data that it adds on to your life expectancy. So why is it that we don't eat them? I think we heard a couple of things. So 10% or the ingredients you're talking about coming from corn, it's only about 10% of the corn that actually goes to our food too. The other 90% is going to feed pigs and cows and chickens in our cars and not people. So there's an awful lot of agriculture is really driven for that, and lots of money goes into driving productivity of corn. And there's a lot of things that we get from that are, I think we wouldn't want to give up. So I don't think we should totally shame corn. It's got a lot of value. But then turn to the, just generally the grocery store. All of the innovation that you see happens in the center of the grocery store, not in produce. So I think it's about 3% of innovation happens in the produce space. You watch the Super Bowl. Do you ever see an ad at the Super Bowl for a healthy salad that you should eat? No. I think the only vegetable I've seen advertised at the Super Bowl is avocados because you got to
From Mexico.
From Mexico, exactly. So there's a lot of things that are pushing us all to not eat enough fruits and vegetables. So when we were starting at Pairwise, we thought this was a worthy thing to take on when this new technology, CRISPR, comes on. Is there something we can do to accelerate the way we advance fruits and vegetables and maybe catch up a little bit with corn? We looked at the types of things that have been successful at driving more consumption of particular fruits and vegetables. And I think one example I like to use is blueberries. I mean, I'm old enough that I remember when I maybe got blueberries fresh like once a year. And normally they'd be frozen in a pancake or something. In the early 2000s, they became, after 60 years of breeding, we had varieties that we could grow in enough places that you can have blueberries every single day. They have pretty good shelf life, so they can ship them a long way. And I have blueberries pretty much every day now. So I probably fulfill the USDA recommendation for eating fruits because I can get things like that. So that's one example. The other example is convenience. And I think what example I like to use is the easy peel seedless mandarin. So those, you think those have been around forever? They actually were introduced in 2013. So they've only been around 10 years. Citrus was a shrinking industry. It's now a growing industry again. And it's the #1 food for kids, or fruit for kids in people's lunches, because you can transport it with you and eat it. And seedlessness in general has been a real drive for consumption. None of us eat grapes with seeds, but we eat a lot of grapes. So we started looking at the crops that don't have seed, that still have seeds. And it's funny, the stone fruit still have seeds because it's not a seed, it's a pit. And we hadn't really figured out exactly technically how to do that. Also the cane berries, so blackberries and raspberries. So we started examining how those are formed, because again, the idea you could make a cherry without a pit, and by the way, we could make it so they're available year round. Now you've got another fruit like blueberries that we could eat all the time. So we've actually now demonstrated in blackberries that seed is actually a pit. We've demonstrated that you can eliminate the seed in a blackberry. Those will be a few years before, probably the end of the decade, before they're available to everybody, but we've demonstrated the first step in that. And we're now working on making a pitless cherry, and then the goal is to make all the stone fruit without stones, and to make them into bushes that could be grown in areas that they aren't grown now. So all of our cherries in the United States are grown in eastern Washington, because it doesn't rain there in the summer, but they have lots of water. But if you could put them like blueberries and grow them under hoop houses, you could grow them anywhere. And also that creates a lot more resilience to climate change and all those types of things.
Climate change, thank you. So,
Well, can I ask him a quick follow-up
Can-
question, because you're our food scientist here? I really do think that we need to be talking more about the gut microbiome and how our food impacts it and how we can adjust it, because there's a lot of people out there who believe that the gut microbiome is the mediator for what we eat turning into disease or restoring health. Is there anything you can impart to us about what you all are doing, or what's on the horizon in terms of learning more about the gut microbiome and how the foods we eat or the foods we design can impact it?
I'd say, I think you're bringing up sort of the complication of a lot of this, and we're trying to make it kind of simple, as it's just help people eat more fruits and vegetables. I think there's great efforts being done to study the microbiome, but I went to the Blue Zone talks this morning, and they're talking about how really it's not, I think he doesn't like using the lifestyle change term, but it's really just eating the right stuff. Adds a lot to your life. So we're not particularly studying the microbiome. Some of the things that we've worked on, there's evidence that they can improve microbiome. So we did launch a product already that was an improved leafy green. It's not on the market right now because we decided to not be a marketing company. We wanted to make more products ourselves, so we've just licensed it to somebody else who will be marketing it. But we took mustard greens, which have a very nutritious value, a lot like kale, but they taste bitter and in fact pungent, so they taste like wasabi. So it's a fairly simple editing approach, as editing is, that CRISPR allowed us to remove that wasabi flavor. So now you can make nutritious salads, so your salad works more for you when you eat it.
And if any of you all want a healthy
Jerome.
hack, I was talking to a news outlet about H5N1, and they asked me about how I get more fruits and vegetables in my diet. And we ended up talking for 20 minutes about my smoothie recipe. And that article got more traction than the H5N1. So again, that's my healthy hack.
So climate. I just want to make sure that everybody's going to bring up climate change. It's a big part of this conference. Local food systems and strengthening them, and that helps fight climate change. And it's a lot of the work we're going to be doing in our best practices guide for starting food as medicine work for places not doing it. How do you strengthen local food systems, Pam?
Well, I was going to answer another question, so let me
Good.
go to the other question.
Go to what you wanted to answer.
I was going to build off of something that each one of these two said. One is the microbiome thing. We try and also keep our messaging very simple, and so it's about healthy eating, and here's examples of healthy eating: eat more fruits and vegetables. I'm simplifying more than it is, but because we don't have universal agreement on the definition of nutrition for the nation, inside Kaiser Permanente, and for the individual. So keeping it simple with getting people to eat healthier seems to be resonating better with both our, and some members of our care teams have a lot of expertise in certain areas, and so they go in directions that are unique, but as a health system, it's keeping it simple. But I also wanted to throw out some numbers into the room, because I think it's important to know the magnitude that we're talking about. So for food insecurity, it's 1 out of 8 households that are experiencing food insecurity. In our membership, we surveyed our members in 2020 and again in 2022, 23, and what we surveyed them for social needs, so like food, housing, transportation, loneliness, and what we saw in food, and we asked them, we actually added nutrition security, so we looked at food insecurity and nutrition security. And so we could see that there is a Venn diagram. It's not an exact overlap. There's a lot of overlap, but not exact. And it's also 25% of our membership, 12.6 million members, 25% of across all lines of business, so older people, people with jobs, and people who are on have Medicaid plans. But if you look only at the Medicaid plans, it's 50%. So that's 1 out of 2 families are struggling with families on Medicaid plans are struggling with food and/or nutrition insecurity, and that's a lot of people. And so just the magnitude of just wanting to bring that in the room. We also have, and then we have inequities within that. So female-headed households, race and ethnicity also creates even higher percentages. And then we have diet-related disease, which we haven't talked about yet. Like that is crazy numbers. We're on a crazy trajectory for diet-related disease, and so it elevates the importance of us having this conversation around what is the future that looks different from the present.
3 things I can't help resist. The largest food bank in Massachusetts did a survey recently, and that food insecurity has increased from 32 to 33 to 34%. Even during and after the pandemic. Part of it is because the ending of the SNAP and WIC restrictions. So SNAP and WIC, these acronyms, when the panelists call for telling everybody you know to help make it easier, dual eligible, a lot of people are eligible for both SNAP and WIC, which both played a part in Jerome's childhood. They don't know it. They think it's one or the other. And so encouraging people to apply for all their benefits, these staggering statistics in Boston, Massachusetts, 43% of adults surveyed reported at least one case, 1 month of food insecurity last year. That's almost half the people when you walk down the streets of Boston. So that is pretty staggering. So it comes down to policies that will help get people more food and prevention. So I'd like to talk to everybody about prevention. How is prevention ever a winning strategy for healthcare policy and healthcare payers?
Yeah, I mean, I think it has to be. We have to start with prevention, and we have to start with things that also don't have to happen inside the doctor's office. So what are the ways that you can address food and nutrition insecurity that don't have to rely on the care teams? And so healthcare is moving into the direction from a regulatory perspective of having to screen for food insecurity, not yet nutrition insecurity, but maybe sometime in the future. And then what are you going to do about it? So if someone screens positive, what are you going to do about it? Yep. So we're all building our muscles here, building our muscles towards referring to local entities. You asked about the local food system, but referrals local, referrals to government programs, again, throwing out statistics here, like WIC, eligible, only 50% of those who are eligible across the nation are actually enrolled. So like, hello, that is a solvable thing. So it's really about just leaning in on all of it and rolling up our sleeves, both inside the care teams, but also outside the care teams.
Outside the care teams. Jerome, you were saying how much you have difficulties with the idea of medicalizing food. And I just have to tell you, food is medicine is a hugely controversial term in the larger food world and nutrition community, because they say food is food. You know, it's not medicine. You know, pharmaceuticals, that's medicine. Stop confusing it. But it's partly to make the case for payment and reimbursement. So do you have any policy changes that could allow more money for nutrition and food, but get away from that medicalizing you object to?
Well, I mean, and not to beat a dead horse, but we really do need to experiment with new payment models. So I actually sit on the board of a company called Absolute Care, and what we do is we take the highest risk patients from insurers' panels, and we actually just wrap a warm community hug around them. Whatever they need, we give to them, and we've shown consistently that we can lower their emergency department admissions, we can lower their cost to the healthcare system when we do that. But It's very hard to get payers to embrace this approach. It's very hard to get government to embrace this approach. Again, still 90+% of payment is fee for service. So we need to break that paradigm. But I also wrote a report when I was Surgeon General that's unlike any other report that came out of the Surgeon General's office, because it wasn't written for a health audience. It was actually written for a business audience. We wrote it with the UVA Darden School of Business, with the U.S. Chamber of Commerce. Healthcare is the #2 cost for most employers right now. And they've been trying for decades to lower that cost, and it continues to skyrocket because they're focusing on the medical model. What can we do to limit the number of providers we go to? What can we do to lower the drugs the expensive drugs that you're able to get? That's not helping. And the case that I made is that we need businesses to lean into promoting policies on a larger level, doing things within their sphere of influence, and actually, they're the ones that are ultimately paying these insurers to provide care to their folks and saying, we need new payment models that allow us to address what's going on. But how many of you all employ someone in here? How many of you all are employers? This is something that I challenge all employers to do, is to just assess your own workers for social needs. You will be shocked if you do an anonymous survey how many people who work for you have housing insecurity, have food insecurity, have nutrition insecurity, have substance misuse and mental health problems in their homes. And so all these folks, I go around and talk to these CEOs at places like this, and they have their nice foundations, and they want to say, what should we be focusing on? And I say, well, look inside your own house first and try to do what you can to improve the folks who are working for you and around you, and then that will spill over into the broader community.
And it's going to take all hands on deck to solve this. Like, it's not one single part of the system that can make this hum.
And when you're talking about, I think what you're talking about was what I often hear referred to as community wraparound services, but
I like my hub
wrapping
term
a
better.
warm community hug. From now on, that's the new term. So let's all go out and popularize warm community hug.
And I hate to beat a dead horse here, but in Indiana, one of the challenges we had, that Pam brought up, is that, again, you had to go to one place to sign up for SNAP. You had to go to a completely different place to sign up for WIC. You had to go to a different place to sign up for different benefits. And so we really worked, when I was health commissioner and beyond, to make it a one-stop shop, to make it easier for folks. So one thing all of you can do is understand what is the process to sign up for these things in your state, and then to call on your legislators, your policymakers, to say, can we make it easier for the people who actually already are eligible for these benefits to actually get them? And then insurers should work with community health workers and community organizations and nonprofits to go out and find these people to actually help them get signed up. That would be the biggest bang for your buck right now. It's not creating new programs. It's actually getting people on the programs that already exist.
Great. I've got 2 questions, one for Pam and one for Tom, and then your questions, so start thinking of them. Pam, why isn't everybody as far-sighted and integrated and integral as you? So how can other people who work within healthcare systems or healthcare payers, which we're always really interested in, how can they help sell this model and the idea of all hands on deck and working together?
Yeah, I mean, I think we're seeing more and more of food as medicine woven into the context of healthcare and into healthcare across the nation, whether you're a health plan, a provider, a community clinic, or even like a school district. Or there are many players, but I think for healthcare, more and more are leaning in and trying to figure out how to deploy it. And it's complicated to deploy some of these inside healthcare. There are workflows, there are referrals, there's bidirectional referrals, there's how do you get it into the medical record. Like, it is very complicated, but what I can say to the positive, and I haven't said this yet here today, there is so much enthusiasm inside healthcare for this work. And really, it's about, like, I'll just speak for myself. In the past, I don't know, 2 or 3 years, definitely in the past 2 years, more and more I've had frontline care teams knocking on my virtual door saying, how can we get more of this? How can we get more tools in our tool belts to treat and prevent diet-related disease and address hunger? So it is thought of as the part of care and the part of future of care. And healthcare to your question, is trying to figure out how to deploy it. And I want to actually, the food as medicine nomenclature, we did a lot of human-centered design around this, and we talked to members, patients, care teams, and our own internal colleagues. It wasn't completely universal, but for the most part, people were good with the term.
No, it's a branding.
They knew what it was, and they could embrace that it was needed. And when we asked if we should change the name, it wasn't a resonating yes. You should. It was anyway. Just to say that.
I don't mind the name. What I mind is if the name then leads to us going down the same pathway and medicalizing it. I don't like the idea that you're going to give someone who's got food insecurity a bag of food for a finite period of time, the way I describe a Z-Pack, and then we're going to say we're going to cut you off at a certain time, and we haven't addressed the broader issue that they need food, and they live in an environment where they can't access food. So I don't have a problem with the name. I have a problem with the name leading potentially down a bad pathway. And I love Kaiser. I got my MPH at Berkeley, did work with Kaiser, and to answer your question, Kaiser can do this because they're an integrated system, so it makes it easier to coordinate, and because they have market share. And I studied health payers from across the country. The reason why they don't want to invest in these things is because there's turnover, and people are going to leave and go to a completely different plan, and they don't have that coordination. And so they're like, it's hard to do, and I'm not going to get the ROI because this patient's going to be on another person's plan by the time the food I'm giving them has a benefit for their diabetes. So what we need is more research to help make the point that this can give both long-term and short-term gains for folks. And what are the best models? You brought all these things up. Who are our target patients? Because you can't give free food to everybody. You just practically cannot do that. So who are our target patients? Where are we going to get the most bang for our buck? Where are we going to get an ROI in the short term? Within the medical side of this, the 20%, and then also challenge them to think about what we can do to build healthier communities that are going to help the 80% overall.
And it has to be a comprehensive approach, I think. Some of those temporary interventions are good for certain things, but then you layer on the SNAP, the WIC, the referrals to a food bank, the other things that are also helpful for someone's longer term, and job creation and all the other things that community investments and partnerships with government, all the other things in a more comprehensive approach.
Jump in here, because we've been hogging the microphone.
You got
in a
know
food
more.
system that has healthier food.
No, I do have a question. First of all, I want to rewind the tape a bit. What Jerome just said about the difficulties of return on investment and patients going from one healthcare system to another, it was brilliantly succinct. And when there is a tape of this online, I'm rewinding that tape and playing that for everybody. That is a huge, important concept in ever talking about food as medicine, investment from the healthcare system. So thank you for that. Tom, is your ideal... I know you're not a salesman. I know you decided you were going to get out of the sales business, but do you dream of having your products served at school lunch? Do you have like dream customers to watch this diffuse around the country? I assume it's going to be more than boutique markets and Whole Foods.
Yeah, absolutely. In fact, that's one of the reasons that we decided we were better off to partner with downstream people who had a broader reach. Now we also have a partnership with Partnership for Healthy America, where we're looking at ways to address how we get food to the right places. And we can do the genetics. There's lots of other people that need to do the other parts of how we address these things. And I think listening to the back and forth here, this is really, really complicated, right? Food is complicated. And yeah, you can't give food away for free because you also have to pay the people who are making the food. In fact, I think many of the people who might be food insecure, ironically enough, are the people who are making our food. So we need to recognize that people aren't really getting that rich in the food system. And maybe just another number to throw out, but I think you go back only 50, 60 years, and people were using about 40% of their wallet was going towards food, and now in America, it's like 6% of the wallet that goes to food. So
I just read it was a full 30% it was 40% in the 1950s. It was much higher in the First World War era, and now it's between 5 and 10%.
Yeah, so amazing what we've done with technology to drive more productive agriculture, or it's just all these other things that become more expensive, so housing and all the other things. So it's not just food insecurity, there's lots of insecurity.
Also externalities and true cost accounting, but we want, this is great. We have a lot of hands up.
Wow.
And we've got Lori in the first row and then Mary in the second row.
Why
then
are
Ken.
they all on this side of the room?
Okay.
Did you all not hear? So you all just didn't like what we were saying over here.
So we're starting with, it's my fault. It's Lori, Mary, Ken.
Okay, thank you. Great panel. Quick question. So when we did the New York City green carts, I don't know, about 10 years ago, it was very, very successful. We put 500 fruits and vegetable carts into the underserved neighborhoods in New York, created 1,500? Over 1,500 jobs. All of that was very successful. Here's my question, though. As a philanthropist, you always want to know that your money's going where it's most needed. Now that we're not doing the program anymore, I can ask this question. Are frozen fruits and vegetables just as good and less expensive? Yes. Okay, thank you. Do I get a refund? No, sir. Yeah, because that never came up. I asked it a lot, sotto voce, but you don't hear it that much. You hear about food deserts, you hear about, you know, the green carts that we did and fresh fruits and vegetables, but people don't talk about frozen as much.
And can't.
And can't.
Except if there's too much salt.
Like low salt, canned salt, also frozen.
Yes, that's it.
Yes, yes.
Frozen's good.
Yes, low salt. Yes, make it low salt. Mary.
Hi, thank you for this, all of you, and for all that you're doing. Mary Woolley with Research America. We're a nonprofit alliance working to improve health and research for health. So thank you for mentioning the importance of research. Speaking of which, just yesterday, we released a brand new public opinion survey on food and nutrition that we partnered with the American Heart Association about. Now, that survey was conducted a couple of weeks ago, so it's brand new. Most of the findings, reflect what you've been talking about today. So I'm not going to go in and reiterate them, but there are some shockers, like 20% of the public saying that they or someone very close to them has experienced persistent hunger in the last year, and that kind of relates to what you were talking about, Jerome. But my question is whether you're working with, you all and others, are working with groups like American Heart, American Cancer, American Diabetes Association, because they are powerful and they care, and they're excellent at making the case.
I love AHA and Regina Benjamin, former Surgeon General's on the board of American Heart Association. They've done a great job pivoting. A lot of the doctors' organizations, and I'm a practicing physician. I'm a member of the AMA and the American Society of Anesthesiologists. They have a great role to play. In many cases, their role is focused on the medical model. It's focused on reimbursement for our providers and the medical model. The AHA has done a good job of recognizing that upstream factors actually matter in terms of changing the trajectory for the people they're trying to serve. And we need more of our professional societies to understand that, hey, yes, we want people to get on the right medications, but if we're... Quick story I love to tell about my boys. I came home one day and there was water coming out of the chandelier in my dining room. I have two boys, and I ran upstairs, and there was water. They'd flooded the tub, and there's water flowing, and my first instinct was to run to the towel closet, and I grab a towel and I throw it down to try to get the water from going into the seam and going down into my dining room. I grab another towel, and I grab another towel, and it hits me. I've got to find out where all this water's coming from and turn off the spigot, because I'm going to run out of towels, and it's not going to make a difference. We need to understand that, yes, sometimes you need a towel, but you've also got to turn off the spigot, and that's the challenge that we have.
Yeah, maybe building off of that, we have a partnership with AHA, and I mentioned the White House Conference on Hunger, Nutrition, and Health. They have a $250 million commitment towards building the evidence. And so if you were to ask me what are the biggest challenges for food as medicine, I would say it's the evidence, so thank you for your work. It's the research on what works and under what conditions. It's also how do you pay for it? You mentioned this earlier. It's also how do you pay for it in a sustainable way. Someone mentioned philanthropy. So it can't be just based on philanthropy because you can't sustain it. So and we need the business case also. So all these things are, for me, a question we haven't asked, but more research, way to pay for it, ways to pay for it, and workflows that work. Like
workflows, that is incredibly important, because doctors don't want to do this because they're like, okay, I find out you're food insecure, now what? I don't know what to do. And so we actually created a digital 211 tool at Purdue where you can actually use it to, you can assess for social needs, and you can give them a customized plan and say, okay, you're food insecure, here's who in your zip code is going to provide food. You're housing insecure, who's in your zip code can help you. We need to look at workflow because that's a big barrier for physicians. You don't want to ask a question that you can't do anything with the answer.
And also, you don't want, I call it the, when the intervention ends, you've mentioned. I call it when the circus leaves town problem, which we're actively working on. When the nutrition intervention ends, what are you doing to sustain access to food in the communities you've studied? We have a lot of recommendations on equity. Ken?
A health and food question. When is organic foods a value, and when is it hype?
Oh, I've got an answer to that. Pam?
I mean, you should answer, and then I'll answer after you.
No, we need to sift this to the other side of the room. Go ahead.
Corby, I said you should answer, and no. For me, I think people should eat healthy food, and organic food, unfortunately, tends to be more expensive, and we need to make healthier food more affordable. So I'm not talking about the pesticide part of the non-organic, but more about like how do we get more healthy food into people's diets, but you can talk about the pesticides.
My answer is we should all buy organics food because the people who raise it are exposed to fewer pesticides and toxins. And
Better answer.
that is
Better
what we
answer.
care-
That's why you
that's what we
first.
care
I would
about.
just
The nutrition
I would
value doesn't
differ.
change.
There are lots of pesticides used on organic foods. They're not synthetic pesticides, and they're actually, many of them are worse for people than the synthetic ones.
And I would actually say, at the end of the day, this is a great discussion to have, but we need
This
to meet
is our
people where they
next
are.
panel.
And
Yes.
how do we drive down the cost of organic food then? Because
Exactly.
Yeah.
Because if you say it's all got to be organic, then what about the people who can't afford it?
Yeah.
You meet
We
people
have,
where they are.
We have time only for, affordability. We have only 2 speed questions. We have 2 people with mics. One is Noah in the front of the room and the gentleman in the back, sorry. Then you can flood us all at the end of the panel. But Josh, we are getting the cutoff signal. So quick, we're going to do ask your questions both at once, then we'll try to address them. Noah.
Thanks so much. So I'm going to take a complementary approach, right? So a lot of what we're talking about from food is medicine, food is health is focused on getting food into people's hands. You know, see the value there. But when you actually look at shopping basket data, probably the most ubiquitous product in America is soda, 97% household penetration. Then when you look in SNAP, about 70% of SNAP households actively spend their SNAP dollars on soda because soda is SNAP eligible. So I guess my question is what is it going to take to get beverages medicine? And I know everyone should drink more water. I should drink more water, especially in Aspen. But telling people that have a nostalgia, have a family tradition of certain things that are unhealthy, to have them to stop doing it, you know, what is it going to take, do you think, to add the complement to
Okay,
basic-
that's your question. Great. Now, back of the room.
Hi, thanks for the question. So I'm Kweko Hazel. I'm a metabolic surgeon. That is, I treat the disease of obesity and diabetes with surgery here in Colorado. And one of the things I wanted to point out is the disease of obesity. We talked a lot about the ADA, the American Heart Association, the American Cancer Association, but all of these chronic diseases are directly related to obesity. And there are people on the forefront of treating obesity, which is the bariatricians and the bariatric surgeons. And my question for you is the history, because here in Colorado, we are one of the healthiest states in the country, probably with regards to obesity, the best. But we're only as good as Mississippi was 25 to 30 years ago. So in general, the trend has been moving in the wrong direction. So was there an inflection point in our history that made food security, nutrition insecurity, and obesity kind of rise up?
Yes,
bet
there
Jerome
was.
has an answer.
Yes, there
And he
was. I
does.
mean, and again, it was when we saw the skyrocketing of corn and corn byproducts going into our food, number one. And number two, that's the difference between food insecurity and nutrition insecurity. And I don't hate corn. I'm from Indiana. I don't hate corn, but we've got to understand a large portion of our federal subsidies are going to subsidize a product which has been shown in many ways to have contributed to the obesity. And it's a problem because people can't see it because they see these obese people and they don't believe that anyone is food insecure, but it's because we're not giving them products that actually, the products that are worse for you and that cause obesity are the ones that are cheapest, and so they're getting calories, but they're getting empty calories. So.
Maybe just adding that if you're in healthcare, you have to take a comprehensive approach to food insecurity, nutrition insecurity, obesity prevention, weight management. All of it has to work together towards how we care for our members and patients.
And to finish with your question in 10 seconds, again, you have to meet people where they are. Just like the organic food conversation, we can have all these esoteric debates about what's best, but at the end of the day, you've got to meet people where they are, and you have to take a harm reduction approach sometimes, because you can't let perfect be the enemy of better.
And one parting shot, and provide choice, because the end user wants choice. They don't want, if I cook, I don't cook. I shop, I don't shop. They want choice.
He's trying so bad back there.
Okay,
He's like,
sorry.
wrap it up.
And I don't want to give politicians a reason to reduce SNAP. Thank you all for coming.